In breast cancer, we've come to rely so heavily on molecular biomarkers. But what if the real key to a patient's prognosis has been hiding in plain sight all along, right there in the mammogram? So in this explainer, we're going to dive into a groundbreaking paper that argues our everyday images can be way more powerful predictors than we think, especially when it comes to the deadliest forms of this disease. Okay, so here's how we're going to break this down. We're going to start with this big problem, what they call the prognostic gap. From there, we'll get into the nitty-gritty of Professor Tabar's imaging biomarkers and see how they apply to those really challenging diffuse cancers. We'll look at the hard data, comparing what's predicted versus what actually happens. And maybe most importantly, we'll talk about how to bring these insights into our daily practice and wrap it all up with the key takeaways. All right, let's dive right in. The whole reason this paper exists is to tackle what's called the prognostic gap. And what is that? Well, it's this huge, sometimes dangerous disconnect between what our molecular markers predict and what actually happens to our patients. For years, we've put so much faith in immunohistochemistry, IHC, to guide treatment. But this paper makes a really bold claim. In a lot of cases, those markers can be dangerously misleading. And this is where the work from the legendary professor Laszlo Tabar and his team comes in. They're essentially saying, hey, hold on, we're overlooking some incredibly powerful prognostic data that's staring us right in the face. It's in the mammogram itself. They show that how a tumor looks on an image, its imaging biomarker, can actually be a far more reliable predictor of a patient's future than some of our current tools. Okay, this sentence right here from the abstract, it's basically the entire paper in a nutshell. It's making a really bold claim that for the most aggressive, deadliest cancers, the mammogram tells the real story, even when, especially when, the molecular report gets it wrong. This is a direct challenge to the way we've all been taught to rank prognostic tools. So, let's look at Figure 1 because it shows this problem in action. On the left, you've got the mammograms and MRI, and you can clearly see multiple masses scattered over a huge area. Now look to the right at the large format histology. It confirms what's really going on. Two totally different cancer types in the same patient. The arrow points to a mucinous carcinoma, while the dashed arrow highlights a diffuse, classic invasive lobular carcinoma. And here's the kicker. They had completely conflicting molecular profiles. I mean, that's a massive dilemma, right? Which tumor are you supposed to base the treatment on? Okay, so to really get what this paper is saying, we have to learn to speak the language of Professor Tabar. Let's break down the key imaging biomarkers, which he so brilliantly classifies based on where the tumor actually starts. This classification is just fundamental to his whole approach. All right, first up, we have acinar adenocarcinoma, or AAB for short. Now, these are the ones that start in the TDLU, the terminal ductal lobular unit. They're the ones we see all the time, right? They make up about 75% of all breast cancers. And for these cancers, the molecular markers usually do a pretty good job. And this slide just lays it out beautifully. These are the 4 classic ways AAB shows up on a mammogram. So in A, you get those powdery-looking calcifications, that's your grade 1. In B, you've got those crushed stone-like calcifications for grade 2. And once it becomes invasive, we see either a stellate mass, like in C, or a more circular one, like in D. The big takeaway here is that for these pretty straightforward tumors, yeah, the molecular markers tend to line up with the outcome. No big surprises. Okay, but now we get to the real heart of the paper, the 2 diffuse and often highly fatal subtypes. We're talking about DAB, which starts in the major ducts, and BCML, which you probably know as classic invasive lobular carcinoma. And these are the cancers where that prognostic gap we mentioned becomes a massive chasm. Wow, okay, this slide really shows you the stark difference. So on the left, you've got the 6 distinct imaging signs for DAB. You see things like casting calx, nipple discharge, architectural distortion. But then look at the right, that's the classic BCMO signature. This huge, sprawling architectural distortion, but with no central mass to pinpoint. According to Tabar, these are giant red flags we just can't ignore. All right, so let's see what this looks like in the real world with some clinical cases, because this is where that clash between what the image shows and what the pathology report says becomes, well, pretty much impossible to ignore. This case is just a textbook example of BCMO. I mean, look at the imaging. It's incredible. You've got architectural distortion covering most of the breast, which is confirmed on the histology. But then the molecular profile comes back luminal A. We're all taught that's a good prognosis, right? Hormone positive, slow growing, and yet, this 81-year-old woman passed away just 23 months later. The image told the real story, the tragic story. Figure 4 highlights another really dangerous situation. You see a small, solid AADB tumor, but it's sitting inside a much larger, diffuse DAB component. So what's the problem here? Well, standard practice is often to biopsy that solid, obvious lump, and if that's all that gets sampled, the pathology report is going to completely miss the much more aggressive cancer that you can see spread all over the mammogram. The patient's real prognosis is being driven by what we see on the image, not what one little biopsy tells us. You think that's complicated? Well, it gets even messier. This is a perfect example of what's called intratumoral heterogeneity. The imaging shows what looks like one big mass, but then you look at the histology, and it's just mind-blowing. You've got two completely different tumors all mixed up in there. And get this, they had opposite molecular markers. One's ER positive, the other's negative. One's HER2 negative, the other is positive. I mean, can you imagine trying to plan a patient's treatment based on a single core biopsy from that? It's a total crapshoot. It's a recipe for getting it wrong. Okay, so this brings us to the hard data, because this isn't just a collection of interesting case studies. The paper brings some serious numbers to back all of this up. And the paper lays out the data so we can answer that exact question. So let's really dig into the evidence, where they put the predicted survival from the molecular markers head-to-head with the actual observed survival based on what the images were telling them. Okay, the evidence on this slide is, well, it's just undeniable. If you look at panels A and B, that's for the AAB types, right? The solid line, what actually happened, and the dotted line, what was predicted. They're practically on top of each other. So molecular markers work great there. But then you look at C and D, for DAB and BCMO. The dotted line shows this nice favorable survival that the markers predicted. But the solid line, the grim reality for these patients, it just plummets. This is the prognostic gap, right there in a graph. This next slide really drives the point home. What it's showing us is that for BCMO, the specific molecular markers just don't seem to matter nearly as much as the imaging pattern. You see the blue curves for the AAB tumors? They act just like you'd expect. But the red curves for BCMO, it doesn't matter. ER positive, ER negative, HER2 negative, the outcome is just consistently tragically poor, way worse than the AAB tumors that have the exact same markers. The imaging, the red line, is telling the real story. And this might be the single most shocking statistic in the whole paper. We're looking at the molecular subtypes for those highly fatal BCMO cases. An absolutely staggering 81% of them were classified as luminal A, the subtype that every textbook tells us has the best prognosis. This one number, 81%, basically is the prognostic gap. It proves that for this huge group of really high-risk patients, it's the image, not the molecular subtype, that's telling the truth. Okay, so what do we do with all this? What does it actually mean for us, day to day? Because this isn't just some interesting academic exercise. The goal here is to actually change clinical practice. How do we take these findings and put them to work in our reports and in our multidisciplinary team meetings? This last case study really brings everything together. So, this patient had two separate cancers, a small AAB in one breast and a huge BCMO in the other. And here's the wild part. The key molecular markers were identical for both cancers. Both were labeled good prognosis. If you didn't have the images, you would be completely, dangerously misled. But the imaging biomarkers, they told the real story. One was a small contained tumor. The other was a widespread, aggressive cancer. And sadly, the imaging was right. It correctly predicted the patient's poor outcome, which was all driven by that BCMO. So, what are the big takeaways for your own practice? The things you can start doing tomorrow? First, if you see multiple tumors, your spidey sense should be tingling about the possibility of different tumor types. Second, when you see that classic BCMO architectural distortion, you've got to flag it. Make it prominent in your report. It's probably more important than the molecular data. Third, if you see a little ABABA hiding inside a big area of DABA, you need to state very clearly that the extensive DABA is what's really driving the prognosis. And finally, for all these tricky cases, we need to be the ones in the room advocating for the imaging biomarkers to be given top priority when planning treatment. And just to really hammer home why this is so urgent, let's look at one last statistic from the paper. So these diffuse cancers, the DAB and BCMO, they only accounted for about 21% of the cases in their study group. But get this, they were responsible for a staggering 45% of all the breast cancer deaths. That is a hugely disproportionate number. So this incredible work by Professor Tabar and his team really forces us to step back and ask a tough but critical question. What it's telling us is that for a really significant and often fatal group of our patients, the most important piece of prognostic information isn't on a pathology report. It's on the images that we, as radiologists, are looking at every single day. It's a powerful call to action, really, to completely reevaluate how we rank our prognostic tools in our day-to-day clinical practice.